Madam, first time we have seen your both of your faces. Till today, both of you were in a mask only.
Yes, sir.
So
Actually,
Sunil Kumar, and both of you now today without mask, so we could recognize at least in future.
sir, we are working from
Thank
home
you.
because of COVID.
Yeah,
That
yeah.
is why.
Thank you, thank you, thank you.
Okay, thank you, Sripriya, and good afternoon, everybody. So we are moving on to the last session. Sripriya, am I audible?
Yes, sir. You are audible.
But I am switching off my video because when it might be low. Okay.
Okay, sir.
So so I will start sharing my presentation. The screen visible?
Yes, sir. Perfect.
Okay. So we already talked about opioids, the opioids in second step of WHO analgesic ladder and third step of analgesic ladder. So in the second step, we discussed tramadol, tapentadol, codeine, dextropropoxine, which all are opioids for mild to moderate. Sripriya?
Sorry, sir. There was a disturbance. It is muted now. Participant.
Yeah, okay. Yeah. So in the third step, there are mainly three strong opioids which are available in India, which are morphine, fentanyl, and methadone. So we talked about fentanyl and morphine, and many of the Indians are comfortable, or many of the Indian palliative care as well as pain doctors are comfortable to use. We have mentioned now. But methadone is a new opioid, or not a new opioid, but it's a new opioid for Indian doctors because that has came into the market in 2018 for analgesic purpose. But previously, the other group of doctors which do substitution therapy for opioid addiction is using methadone, and they continue to use it. But we don't use it for pain relief until 2018 when it became legally available for pain relief in India. So today we are going to talk about the foundation for starting methadone for patients. So it is methadone is very different from other opioids. So we should know about the pharmacological properties of methadone. And many, even though many might have heard about methadone, they might have heard about the negative aspect or the risk of methadone, not the benefits. So it is important for us to compare the benefit as well as risk of methadone in pain management. And it's not like morphine. We have to monitor the patient frequently with some parameters. So we should also need to understand what are those parameters. Then another thing would be not all patients require methadone. So we should understand which patients need methadone and how can we convert from an opioid to methadone. This is also important. So these are the topics which we are going to cover in today's session. So before moving on to the session as such, I think Sripriya has a poll. So first we will launch the poll and then we will move on to the session as such. Sripriya,
Yes.
it's all you.
Yes, sir. Thank you, sir. So just briefing the ground rules of the poll. The poll will be in two sections, poll 1 and poll 2. Poll 1 will be having 7 questions and poll 2 will be having 8 questions. So you just have to choose the answer which seems most appropriate to you. Do the same process for all the 7 questions or 8 questions and then finally submit. I hope I am clear. There will be a time limit for the poll. The first poll would be ending in 3 minutes and the second poll in 3.5 minutes.
So this poll will not be considered for any types of assessment. So you can freely do or select the answer whichever you want.
Okay. So launching the poll 1, you will be getting a prompt in your screens right now. Poll 1 launched.
We will discuss the answers if needed at the end of the session. Okay. So is the PowerPoint visible?
Yes, sir.
Okay. So first we will talk about the methadone pharmacology. So all of you know that opioids act uh, by sticking onto the or attaching to the opioid receptors. So mu, kappa, delta are the opioid receptors, and many of the opioids or the step 3 opioids which commonly used, morphine and fentanyl, those are mu agonists. Tramadol, tapentadol, all are mu agonists. But if you look at methadone, it actually is a mixture of two isomers known as S-methadone and R-methadone. In addition to action on mu receptors, it also acts on delta and kappa as agonist. So it acts on all opioid receptors as agonist. So it will have more pain. And it is also an NMDA antagonist. So which is the NMDA antagonist, you know? Anybody can answer. Which NMDA antagonist do you know? Shreya, I think there are certain messages coming.
Yes, sir. It's a majority of the responses are ketamine.
Which one?
Ketamine.
Yeah, ketamine. So,
Dr. Sanjay, Dr. Geraldine, Dr. Shiva.
yeah, okay. So, methadone is also an NMDA antagonist, like ketamine. And it also inhibits serotonin and noradrenaline reuptake. Action of serotonin and noradrenaline reuptake inhibition is like another group of medication, which is that group of medication. Anybody? Any response coming in?
It's a TCA.
Yeah. So it's this action is like tricyclic antidepressant, which acts on it inhibits the reuptake of noradrenaline and serotonin. So there are three mechanisms of action by which methadone becomes superior analgesic in the group of opioids. So it acts on mu, delta, kappa, and opioid receptors. It is an NMDA antagonist, as well as it acts like tricyclic antidepressants. Those three actions makes the methadone a good analgesic. But there is something which is not beneficial or harmful, or which may be harmful. It's the action on human either a-go-go gene, HERG, which is known as human either a-go-go gene, which is abundant in smooth muscles, but it is more in myocardium. So when methadone acts on this HERG, human either a-go-go related gene, sometimes it can produce toxodepolis, and then it causes sudden death of the patient. So this is the scary thing about methadone, and many of you might have heard about this effect. tossed points. But we need to talk about detail about that in the coming slides. Okay, so we will look upon all the actions. The first action, which I told you, was opioid receptor agonist on action on mu, kappa, and delta opioid receptors. So it will definitely produce analgesic effect, but as well as its side effect also. So constipation, nausea, urinary hesitancy, pruritus, respiratory depression, all those can occur as a side effect. Next, we talked about the NMDA antagonistic action like ketamine. So anybody can tell me what is tolerance?
Tolerance may be a tolerate the drug without any side effects.
Okay, yes, sir. Anybody else would like to give another definition?
Tolerance basically takes place when with the continuous use of the drug, the patient basically requires higher amount of the drug to produce similar kind of effect.
Yeah, thank you. Suppose a person who is getting good pain relief with 10 milligram of morphine, but maybe after 1 week, the patient needs 20 milligram to get the same pain relief, and it goes on increasing, maybe up to 100 milligram to get the same amount of pain relief after 4 weeks. So you need to take more amount of the medicine to get the same effect. That's what is known as tolerance. So you can
Sir, is it not a tachyphylaxis?
It's not a tachyphylaxis, and this is tolerance.
Sir, in tachyphylaxis, sir, basically the tachyphylaxis, basically the drug stops, basically producing the effect, sir. Even the large amount of the drug, the patient does not have the effect, sir. So, but in tolerance, sir, gradually the amount is little required is more, but you definitely get the effect, sir. In tachyphylaxis, you don't.
Okay. Thank you.
Okay, thank you, Dr. Nitish. So you can see here, and there are 4 patients, and they are on different doses of morphine. And you can see these are fairly higher doses. One patient is on 1000 milligram, another patient on 2500 milligram, and the other one on 7000, and the other one is 12,000. So probably you will not see patients like this, but these are some patients which has been described in literature. And so probably these patients have had tolerance, and that's why they needed this much doses of morphine. So in these patients, they started on 10 milligram methadone every 8 hours, and all of them got a very good pain relief. Okay, so this is because of the methadone can prevent and reverse the tolerance. And NMDA is one of the receptor involved in tolerance. Okay, so you may see many patients on higher doses of morphine or any other opioids, and in such patients, it is probably due to tolerance. And in such cases, if you start on methadone, then probably that tolerance can be reversed. So this is because of NMDA antagonism. And you also know that because of the NMDA antagonism, it is beneficial to treat neuropathic pain also. But you can see that all the patients, the patient who was receiving 1000 milligram of morphine and the patient who is receiving 12,000 milligram of morphine, they have started only on 10 milligram 8 hourly, and all of them got very good pain relief. So 12,000 did not require some 100 milligrams of methadone. So this is what you have to understand. Usually we need not require higher doses of methadone to get pain relief. So maximum advisable dose for pain relief is 30 to 40 milligram. And we also talked about the tricyclic antidepressant-like action. Because of this, you have methadone has got good action in neuropathic pain, but it also has another problem or side effect known as serotonin syndrome, which can occur if you combine it with the medications like fluoxetine, sertraline, other SSRIs, tricyclic antidepressants, etc. So you can see the risk here classified as high, medium, and low, depending on the medication. So if you use methadone along with the fluoxetine, sertraline, paroxetine, bromipramine, or MAO inhibitors, then there is a great chance of producing serotonin syndrome. If it is used with the tricyclic antidepressants or citalopram or escitalopram, the chances are maybe. So what are the points towards serotonin syndrome? So it can be grouped under 3 headings: cognitive changes, autonomic instability, and neuromuscular changes. So you can see patient can have agitation and increased body temperature, tremor, cogwheel rigidity, seizures, etc. So if any patient on methadone and you have started him on tricyclic antidepressants or SSRIs or things like that, and the patient has fever, agitation, tremor, then just think of is it due to serotonin syndrome? So this is I just want to introduce this concept of serotonin syndrome to you, so that you will understand that there is something called serotonin syndrome, if at all it occurs in a patient. I haven't seen any patient with serotonin syndrome. So what are the indications of methadone in pain management? So I already told you that methadone is used as an opioid, used as a substitution therapy in opioid use disorder. But in pain management, if the patient needs around the clock pain management, then methadone would be better choice. If the patient has a renal impairment, and if the patient has complicated neuropathic pain, if there is tolerance or hyperalgesia due to other opioids, then opioid neurotoxicities like extreme drowsiness, myoclonus, delirium. Then some patients may allergic to other opioids like morphine or fentanyl. So in such situation, you can use methadone. And adverse effects is almost like other opioids, but the two things which we already discussed are serotonin syndrome and prolonged QT interval, which may lead on to toxicity points. And if you look at the absorption, it is absorbed through many routes. And per oral availability of methadone is 80%. Can anybody tell me what is the oral availability of morphine? %. Yeah, it is very less, maybe 10 to 20%. But here it is 80%. And morphine is not absorbed sublingually, but methadone is absorbed sublingually, and it can also be used through rectal route. And the injectable preparations are available, but not in India. And after absorption, what happens to methadone? There is a rapid alpha phase in which you can see the methadone concentration in the blood for 2 to 4 hours. But after that, the methadone will go into the tissue binding sites, mainly in brain, liver, kidney, etc. And so that methadone will not be there in the blood. It will be all in the tissues. And after that, next 8 to 60 hours, what happens is it gets slowly eliminated from the body. And average elimination half-life is 22 hours. So you can see here, when you administer methadone, 2 to 4 hours it will be there in the blood, then it will go into the tissue binding sites. Once the tissue binding sites are saturated, so here you can see the tissue binding sites are saturated. Then once it is saturated, when you administer methadone, from the tissue binding sites, the amount which you administered will get dislodged from the tissue binding sites and will be released into the plasma, which will give pain relief. So the most important thing is that for opioids to have a steady level of concentration in the blood, it will take about 5 half-lives. So in case of morphine, the half-life is 4 hours. So it will take about 1 day, that is 24 hours, to have the steady state of blood level. But in case of methadone, the half-life is 22 hours approximately. You can say it's 1 day. So it will take 5 to 7 days to have the steady state of blood level with methadone. So this is the most important thing you have to understand with methadone. In case of morphine, you can increase the dose of morphine every day after 24 hours. But in case of methadone, you have to wait for 5 to 7 days before increasing the dose. This is one of the most important principles in methadone administration. And mainly the metabolism takes place in liver, like morphine. But the problem is that there are many enzymes or cytochrome P enzymes involved in the metabolism of methadone. And you can see cytochrome P2, P6, 3A4, 2D6, C19, etc. So because of this problem, there are many drug interactions, because many drugs will be metabolized by various cytochrome P enzymes. So there will be an interaction with the methadone for many medications. So this is another important thing which you have to keep in your mind while you start methadone. And you have to see what all medication the patient is taking. So we talked about torsade points. So what are the risk factors for torsade points? So electrolyte abnormalities, mainly sodium, potassium, and calcium, potassium, and magnesium. And elderly individual, female gender, structural heart disease, genetic predisposition. So there are various factors for torsade points. I'm not going into details about this. And you can see the methadone doses more than 45 milligram per day. Usually we require only less than 30 to 40 milligram per day to get good pain relief with methadone. So how can you monitor the patients? So there are various strategies you can see in literature, but there are some basic requirements for monitoring the patients on methadone. But another important thing you have to consider is that before going into the monitoring, you have to see what is the goal of care of this patient. Is it comfort care, or is it curative treatment, or something like that? So you have to be very clear what is the goal of the care. If the patient is having only some 1 month to live, then you may not monitor the patient aggressively. But if the patient is treated with a palliative or curative intent, then you have to monitor the patient aggressively. So the baseline investigations which are required is ECG, so that you can calculate the corrected QT interval. So if the corrected QT interval is more than 450 to 460 milliseconds, then you have to rethink, should I start the patient on methadone? And if it is more than 500, it is an contraindication to start the patient on methadone. And the electrolytes which you have to see is potassium, magnesium, and calcium. So all this can produce increased QT interval. And how can you follow up this patient? So once at first, when you start the patient on methadone, you can do an ECG. Then after 2 to 4 weeks, and when the dose reaches 30 to 40 milligram, And the next ECG would be when the dose reaches 100 milligram per day. But we usually, there is no situation that we need to go to 100 milligram per day. And you have to see even you can actually call the patient and monitor the patient daily for any side effect. So as I told earlier, it will take at least 5 to 7 days in healthy people to have the steady state. But in case of elderly individual, and if the patient has hepatic impairment, it will take more days, approximately 2 weeks. So if you start the if you see an elderly and start him on methadone, be careful that you will not increase the dose of morphine till at least till 10 days. So what is the association between the dose of methadone and QT interval? So it is, if you look at the literature, you can see that methadone can increase the QT interval and it can lead on to torsades. But most of the studies have been conducted on patients who are on oral substitution therapy. And usually these patients require hundreds of milligrams of methadone for oral substitution therapy. So when the dose of methadone is increased, the chance of getting torsades points are more. So this is a study conducted by MD Anderson Cancer Center, and they have recruited about 100 cancer patients and started them on methadone, and all of them needed less than 50 milligram of methadone, and they monitored the patient with ECG at the start of methadone, then at 2 weeks, 4 weeks, and 8 weeks, and they have seen that there were no no patients reported torsades points or ventricular fibrillation. So this is one study which says the smaller doses of morphine, smaller doses of methadone should be okay, or it may not produce torsades points. And we already told that methadone is metabolized in liver, and various cytochrome P enzymes are involved in that metabolism. So because of that, because of many types of cytochrome P enzymes are involved in metabolism, there is a chance of drug interaction also. So you can see there are many medications which can cause cytochrome P inhibition. So when there is cytochrome P inhibition, the methadone metabolism is delayed, and with the resultant increase in the increased methadone in the blood. So there are many things like grapefruit. What is grapefruit? Anybody?
It's orange-like fruit.
Yeah, it's not grape. It's another fruit, which is not. I don't think it is available in India. So grapefruit is not grape. Okay. Then protease inhibitors, which usually the patients on antiretroviral medication, azole antifungals like fluconazole, ketoconazole, etc. Cyclosporin, cimetidine, macrolides like azithromycin, clarithromycin, amiodarons. So azithromycin and azole antifungals, these are the common medication which we use in palliative care. So be careful when we use azole antifungals and macrolides along with methadone. There is a chance that the blood level of methadone can be increased. And there are many medications which can induce the cytochrome P enzymes so that the blood level of methadone will be decreased. So these are phenytoin, smoking, phenobarbital, carbazepine, rifampin, carbamazepine, St. John's wort. What is St. John's wort? Anybody? So this is a plant which is not seen in India, but in Western countries, and they use it for many purposes, for treating depression and many things, for treating mental health problems. So what you have to understand is, in addition to this, in India there are many Ayurvedic preparations available, and many other systems of medicine. So we don't know what all medications or what all systems of medicine can interact with methadone. So this is something which you have to keep in your mind. And drug interactions. So when you start an inhibitor, then you have to reduce the dose of methadone by 25 to 30%. Example, if you start patient on fluconazole or azithromycin, then maybe you have to reduce the dose by 25 to 30%. But when you stop an inhibitor or start an inducer, you have to monitor the patient and then only make adjustments. So who are the appropriate candidates for methadone? Even though the word adjuvant will not be correct fitted here, so we know that adjuvant is a medication whose primary action is not analgesia but is helpful in some painful condition. Why this word is here? In literature, when they use methadone in small amounts, for example, if a patient is on methadone, he has good pain relief for most of the time, but at night he need to wake up because of pain. So in such patients, if you use a small amount of methadone, like 1 to 2 milligram, the patient will get good pain relief and he will not wake up at night. So if you use methadone like that, then it is called as an adjunct in literature. Okay, so don't get confused. And if the pain is refractory to other opioids, so there is a patient who is on 100 milligram of morphine, or you tried him on fentanyl, morphine, higher doses, no pain relief. So in such patients, methadone might give pain relief. And if the patient has significant renal problem, morphine may be risky. So in such situation, methadone can be used. And need for long-acting opioid. So you know that morphine can act for only 4 hours, but methadone can act for 8 to 12 hours. So maybe it need to be given only twice a day or thrice a day. And patients on high doses of opioids, which we already seen at the start of the session, and the doses which is required for preventing and reversing tolerance is very less. Then if the patient has if patient has some toxicities like myoclonus, delirium, etc., then maybe you can start the patient on methadone. And if there is allergy to other opioids, then methadone is a good medication. So these are some indications or appropriate candidates for starting methadone. And who are the inappropriate candidates? So most before starting methadone, you have to ask a few questions to the patient and family. You have to ask, is there a family history of sudden unexplained death in your family? And in some families, the QT syndrome is congenital, and the QT interval of corrected QT interval more than 500 milliseconds. And if the patient has poor cognitive function and lives alone, and without reliable caregiver support. So if the patient doesn't have a reliable caregiver, it would not be wise to start on methadone, because methadone is not like morphine. If you give maybe a double dose of morphine, it may not cause much problem. But if you administer methadone for a few days and the dose is not correct, then probably the patient will have more profound side effects by the end of 1 week. So if the patient doesn't have a reliable caregiver, please don't start the patient on methadone. And if you are unable to follow up the patient, and if the patient is in acute pain crisis or acute pain management, short-acting opioids are the choice of pain medication. So this is the methadone which is available in India. It is available as tablet as well as syrup. So tablets are 5 milligram tablets, and in syrup it contains 1 ml, 5 milligram in 1 ml. Okay, we don't have injection in India, and you can see the trade name is Arm, and this is produced by only one pharmaceutical company, the Rusan. So we will move on to the methadone conversion. We talked about the pharmacology and appropriate candidate for methadone therapy. So now we'll see how we can convert from an opioid to methadone. Okay, so when you convert to tramadol, you have a fixed potency ratio. Like if it is tramadol, you will say that it is 1/10 as potent as morphine. But in case of methadone, you cannot say like this. The potency varies with the dose of opioid. So you can see if the patient is taking less than 60 milligram of oral morphine per day, then the initial dose of methadone recommended is 1 milligram 12 hourly to 2.5 milligram 8 hourly. That means 2 to 7.5 milligram per day. So this is applicable in if the patient is taking less than 60 milligram of oral morphine per day, or if the patient is opioid naive. The next one, if the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and if the patient is less than 65 years old, the conversion ratio is 10:1. That is 10 milligram of oral morphine will be equivalent to 1 milligram of methadone. But if the patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years, the conversion ratio is 20:1. That is 20 milligram of oral morphine will be equivalent to 1 milligram of methadone. So as I told you previously, whatever be the dose of morphine, if the patient is on 1000 milligram of morphine, then if you take the conversion ratio 20:1, because it is more than 200 milligram of oral morphine, then the dose will be 50 milligram. You need not start the patient on 50 milligram, rather you will start patient on 10 milligram TID. Or even if the patient is taking 15,000 milligram of morphine, you will start him on 10 milligram TID. And when will you increase the dose of methadone? You can see if the patient has a normal liver function, you have to wait for 5 to 7 days, because this much days will take 5 half-life means it is 5 days. So you have to wait for 5 to 7 days. But if the patient is elderly, then you have to wait for 10 to 14 days. And we will move on to the calculation as such. So this is the patient, 37-year-old man with who was diagnosed with carcinoma of the buccal mucosa in 2018, and he underwent treatment for the same. But at the same time, he had another primary papillary carcinoma of the thyroid, for which he underwent surgery and radiation. And in 2019, he had level 2 normal recurrence, and he again underwent surgery. and you can see his main problem is pain. You can see his posture. Uh, he says the pain is starting inside the left ear, going back to head, then to submental region. It is pricking 10 by 10. The treating doctors tried with many medications, which didn't had any relief. So they did the extra oral mandibular nerve block thrice without any pain relief. So they also started him on injection morphine, but it produced more toxicity. So they stopped it and started the patient on tablet morphine like this. 10, 15, 10, 30. So with which the patient had the symptoms of toxicities. And they also tried on by other agents like amitriptyline and other neuropathic pain agents. So this was the prescription when the patient came to us. Tab morphine 10, 15, 10, 30. Tab antibiotic 40 milligram OD. Tab ciprofloxacin 500 milligram BD. Acetalopram 10 milligram BD. Sarashapeptidase 100. Diclofenac patch 1 every day. Tab paracetamol 650 milligram 1 SOS. Is this patient a candidate for starting methadone? Anybody?
Yes, sir. The patient is having toxicity with tablet morphine, so he can be started with methadone.
Okay, thank you, Dr. Badida. Any other indication to start this patient on methadone?
Methadone can be also been as started as an adjuvant also over here.
Yes, that's right. It can be started as an adjunct. Is there any more indication?
Is a neuropathic pain?
Yeah, it's a neuropathic pain. So that's also another indication to start the patient on methadone. So you are going to start this patient on methadone. So before starting, what all questions would you ask to this patient?
Firstly, as we said, the first question will be any history of any sudden death in the family.
Yeah.
And,
ECG can be taken.
Yeah, but before moving on to investigation as such, we have to see what is the goal of care. That's what you have to understand. All the patients need not undergo with all the investigations, but maybe ECG. Yeah.
We have to ask if the patient is alone or he is with a caregiver.
Yeah, caretaker.
Yeah, is there a reliable caregiver? So first question is there a family history of sudden unexplained death? And if there is an ECG available with you, you can look at the corrected QT interval. Then you can ask who will be with you to administer medication. Yeah.
In our culture, sir, first point is whether he is going to come for the follow-up.
Sorry.
Whether patient is going to come for the follow-up, that is the most important thing in
Yeah.
our culture.
Yeah, yes, sir. Yeah, that's also very important. Are we able to follow up the patient? That's very important. So reliable caregiver, history of sudden unexplained death, ECG, and you can see there are many medications here. As I told you earlier, there are many drug interactions because various medicines are metabolized by cytochrome P enzymes. So the ciprofloxacin, escitalopram, pantoprazole, all has interactions with methadone. And actually, in this patient was not depressed. Patient was in severe pain, but they started him on escitalopram. And pantoprazole has also interaction. Ciprofloxacin is fluoroquinolones as such has interaction with methadone. So We changed ciprofloxacin to another antibiotic, changed pantoprazole to ranitidine, stopped citalopram. Then the paracetamol was continued as such. So anybody can tell me what would be the dose of methadone we are going to start in this patient, and explain why that much dose is required.
To start with, we can go for 1 milligram 12 hourly, and after 7 days, we can change that depending upon the requirement of the patient. We can subsequently increase the dose.
Okay, thank you, Dr. Nilesh. Anybody else?
There will be 2 points. If it is used as an adjuvant, you can use with the low dose. But if you are going to replace the morphine, then you have to increase the dose. I think. So
Which
way
one?
You are going to use?
Yeah, which one do you want here to start methadone as an adjuvant, or you want to replace morphine with methadone?
Initially, we can think of an additional only. And then if it is good, then we can change over to replace it. Because the toxicity is also there with the morphine. So better to switch over if the patient is going to come and follow up regularly and we are going to monitor.
Yeah. So this patient has toxicities. So it is better to replace morphine with methadone. So how do you reach, or Dr. Nilesh told 1 milligram 12 hourly. So what is the total dose of morphine this patient is receiving?
65 milligrams.
65. Yeah.
65. Yeah. And what is the age of this patient?
37 years or 30.
37. Yeah. If he was an elderly, then probably we might have started him on 1 milligram 12 hourly. But he is 37, isn't it? So maybe we can start him on little higher dose. Okay, so this is the calculation. So he is receiving total daily dose of 65 milligram of morphine, and he's sorry, this is 37. 37. So the conversion, you can take the oral morphine equivalent is between 60 to 199. So the conversion factor is 1/10. So 65 divided by 10 is equal to 6.5 milligram of oral methadone. So you can either give, if it is syrup methadone, you can give the 3 milligram BD or 2.5 milligram. If it is tablet, you can give only 2.5 milligram BD. If it is syrup, you can give 3 milligram BD. So when you start patient on methadone, then suddenly the patient was taking 10 milligram 4 hourly morphine. And as I told you earlier, methadone will take about 5 to 7 days to have the blood level stabilized. So till that time, we have to give morphine on an SOS basis. So you can see, in addition to methadone, you are also giving tab methadone on SOS basis, Q4H SOS. Okay, so if you were writing morphine normally, it would be tab morphine 10 milligram Q4H and SOS. But here you can see we have given morphine, tab morphine 10 milligram Q4H SOS. Okay, so this is what you need to be careful. So what does this mean? Suppose you have given methadone to the patient at 6 a.m. and at that time you can ask the patient, do you have pain? Patient say, no, I don't have pain. Then you don't give morphine. By 10 o'clock, you can go and ask the patient, do you have pain? Patient says yes. Then you give 10 milligram morphine. And at 2 p.m. also patient says, I have pain. Give morphine. At 6 p.m. patient, no pain. 10 p.m. no pain. So you are not giving morphine at that time. So this
That
patient
means,
was
sir, every 4 hours we need to 6 hours we need to reevaluate the patient and ask whether the patient is having pain. In
yes,
case the
yes,
patient is having pain, then only we have to give 10
yes,
milligrams of morphine, or otherwise
yes,
not.
yes, yes. You are right.
Okay, fine. Thank you.
It's 4 hourly, not 6
So,
hours.
so that remains for 4 to 5 days. Will it remain for 4 to 5 days? So do we need to admit that patient for that reason?
Actually, if we don't admit the patient to start on methadone, you can do it on an OP basis.
Then it will be difficult to ask for 2-3 times in a day if his patient is discharged.
But yeah, that depends. If the patient understand it correctly, then probably you may not need to admit the patient. But if they are unable to understand things like that, so maybe you can admit them.
I think depends on the who is the caregiver.
Yeah. Okay. So this patient was started on tab methadone 2.5 milligram BD and tab morphine 10 milligram Q4HSOS. And with that, he had better pain relief. And on after 7 days, the methadone was increased by 2.5 milligram. And it was again increased to 3.75 to 3.75 after 10 days. So what you have to understand is this patient was in severe pain and his caregivers were also in severe distress because they did a nerve block and many other medications they tried, but didn't had pain relief. So all of them were in equal distress, including us. But we are happy to see that this patient got good pain relief with methadone, which was failed with the interventional pain management.
Sir,
Yeah.
when patient came, he was not controlled with 65 milligram of morphine. So
Yeah,
can't we increase the dose from the beginning, because it is already not getting analgesic effect with 65? So can't we increase the, rather than 2.5 giving initially, start with 5 only?
No,
Initially.
this patient had toxicities with 65 milligram of methadone. I'm sorry, morphine. So we didn't want to start the patient on a higher dose. That's why we didn't start him on a higher dose.
So can we start it with the 5 milligram only? Methadone.
No, I think
BD.
it is always better to start on a lower dose rather than a higher dose, because the effect of methadone will be seen after only 5 to 7 days, and it will be very difficult to reverse the side effect with the methadone because of the longer half-life.
That is true, but what happens if they don't get an analgesia, they will change the doctor. Rather, here the problem is like that. Everywhere the patient is so furious that they will be changing the doctors. So I think when 65 was not enough, that means their requirement of morphine dose may be around 90-100 milligram, but he was getting toxicity. That's why he was not taking. So considering those facts and seeing this case study, even afterwards we had to increase. So little bit on a higher side we can start, because still we are in a safe zone of the methadone.
No, I agree with you, but I also want to disagree with you, because this patient developed toxicities because the morphine was not responsive to the neuropathic pain that he had. So that's why he had neurotoxicities. So when we calculate like it is 90 milligram and then converting to methadone, I don't know. This we can only got this result only retrospective. No, so if we started another patient on higher doses of methadone, then probably I don't know. It can cause more of side effect, which can even be more detrimental to the patient and family.
Okay.
So I think in case of opioids, it is always better to start at a lower dose or optimum dose. So this is, I think, is the optimum dose with which we started him. Because with tab methadone, we could start him only 2.5 milligram BD. So if it is syrup methadone, then we could have started him on 3 milligram BD. But later we got syrup methadone and we increased to 3.75. That's what happened. So we will move on to the next patient.
For tablet, 3.75 would be very difficult.
Yeah, it will be very difficult. You are right. So we had a 39-year-old woman who has carcinoma of the pancreas, stage 4, with liver, lung, and splenic metastasis, and she received 5 cycles of chemotherapy, but the oncologist stopped the chemotherapy because of progressive disease, and she was receiving palliative care only. So this is the pain pattern of the patient. Pain was there for the last 2 months. It was continuous pain, and the pain score is 8/10, which increases to 10/10. It is continuous, and it starts on left lateral aspect of chest and abdomen, goes to the back, and the patient says it is stabbing, and movement increases the pain. And she was taking morphine plus tramadol plus paracetamol, with which the pain come down to 7/10. She was unable to sleep and depressed because of the severe pain which she was experiencing. She was saying, I am unable to sleep properly even for a day for the last 2 months. And I am unable to take care of my children because of this pain. So this patient had myoclonus. She was on this medication, tab morphine 20 milligram 6 hourly, injection tramadol 100 milligram IV TIV, injection paracetamol 1 gram 6 hourly, tab gabapentin 100 milligram TID, amitriptyline 25 milligram XS, and bisoprolol 5 milligram XS. So what are the indications to start this patient on methadone?
Maybe myoclonus.
Maybe myoclonus, but at the same time, the thing is, despite of being on morphine, tramadol, and adjuvants like gabapentin, amitriptyline, despite of all these, the patient does not have adequate pain relief. The thing is, from 10/10 to 7/10, again, the patient is landing up in a severe category only. And we tend to increase at least to 0 pain, or maybe come down to 3/10, something like that. So maybe the patient does not have adequate pain relief. So we have to basically go for a medicine which gives the adequate pain relief to the patient, and that should be shifted to methadone.
Okay. And in addition, the patient's pain looks like neuropathic pain, like also. So those are the indication to start the patient on methadone. So you will ask all the questions that we have asked previously, and this patient is purely on a comfort care. So I won't do any investigations for this patient. But how will you calculate the dose of methadone required for this patient? What would be the conversion factor? I'll give you 2 minutes to think about this.
10:1.
Anybody else?
10:1 is fine, but we have to stop amitriptyline and maybe gabapentin as well.
Sir, can you combine tramadol with morphine?
How is the conversion from tramadol to methadone?
Actually, it is not needed. One of the doctors started her on morphine and tramadol. So, and this actually should not be done.
Because we should
One
not
is-
combine morphine.
yeah. One is a One is a strong opioid and the other one is a weak opioid. So only thing you need to do is increase the dose of the strong opioid and stop the weak opioid. So 10:1 conversion factor. Can anybody explain how did you get 10:1?
Actually, 5 milligram of methadone is equivalent to 30 milligram of morphine, if I'm right.
No, it should not be calculated that way. First of all, you have to find out the dose of morphine which this patient is taking. Then only you convert to methadone.
This is 80 milligram. So it is between 65 to 199.
But at the
Yeah.
same time, the patient is also having tramadol. Tramadol conversion to morphine is 1:10.
Yeah.
So
that also still remains under the range of 65 to 199.
yeah, absolutely. That's absolutely true. What I'm trying to say is we can add tramadol to morphine or rather the conversion.
Yeah. So we have to take or convert all the opioids to equivalent dose of morphine. So we have to convert tramadol also to morphine. So this patient is taking tab morphine 20 milligram 6 hourly. That means 80 milligram. So
Yeah.
morphine equivalent will be 20 into 4, 80 milligram. But this patient is also taking tramadol 300 milligram. So the conversion ratio would be 1:10, which will be equivalent to 30 milligram of morphine. So total daily dose of morphine this patient is taking is 110 milligram. So which will again fit in the category of 60 to 199 milligram. And the patient is 39-year-old only. So 60 to 199 milligram, the conversion ratio will be 10:1. So what would be the starting dose? It would be 11 milligram. So if you have the tablet, it is 5 milligram. So maybe you can
5
start
milligram
with
BD.
5 milligram BD. So we actually started this patient on 5 milligram BD. Tab morphine was continued on a Q4HSOS basis. We didn't stop gabapentin and amitriptyline immediately, but after a few days we stopped it. So this patient actually had a very good pain relief, and she was very happy for the 2 months she lived, and she was able to take care of her children, and she was actually very happy and called us to tell that I am very happy. I had very good pain relief. So this is another patient. With this, I think we'll stop. We have a 40-year-old man with advanced malignancy of lung who is complaining of pain on both lower limbs due to T12 compression due to metastasis from lung. He was complaining of burning pain on both lower limbs, which was continuous. And this patient is on 40 milligram of morphine 4 hourly and SOS. So you want to start this patient on methadone. How do you calculate the dose? Anybody? Sorry?
That comes to 240
I think
milligram. 240 milligram. More than 200.
Yeah.
So it will be 20:1.
Yeah. Okay. So morphine total daily dose would be 240 milligram. Conversion factor is 20:1. So which would be equal to 12 milligram of methadone. So you can start the patient on if it is tablet only available, then you can start him on 5 milligram daily, or syrup is available 6 milligram daily, or even 4 milligram PID. And you have to continue the morphine on a Q4 SOS basis. And you can get more information regarding cytopropy interactions from this website, and which are the medications which can prolong QT interval can also be seen from this credible match.org website. So in short, methadone is a useful medication in selected group of patients. But you have to be careful while starting the patient on methadone, the dose calculation and the patient, what the medication the patient is taking, including the other systems of medicine. You have to see what we don't know what all medication from other systems of medicine can interact with methadone. And a few important points are you have to wait up to 5 to 7 days before increasing the dose of methadone if the patient is healthy or if the patient's fever is normal. But if the patient is elderly or if the patient has hepatic impairment, it will take up to 2 weeks to get the blood level stabilized. So wait for 2 weeks. And always ask about the history of sudden unexplained death in the family and for a reliable caregiver, and will it be possible for us to follow up the patient? At the same time, you also need to look into the medication the patient is taking, because many of the medication which we use in palliative care can interact with methadone, and either it can increase the dose of methadone or it can decrease the dose of methadone. So the common medications which can increase the dose of methadone are antifungals like fluconazole and and there are many more medications also.
Fluoroquinolones.
Fluoroquinolones and macrolides and azola antifungals. These are two groups which you have to be very careful. And if haloperidol is another thing which you have to be careful if it is given intravenously, especially. So please see what are the medication the patient is on and decide whether we can stop it as such, or we can reduce the dose of medication, or can change over to another medication. If the patient is on macrolides, can we change it over to maybe some amoxicillin, which doesn't have interaction with methadone? And always look for patients. When you, the biggest barrier when you start the patient on methadone for the first time would be, can I do this? Can I go like this? There will be many doubts. So it is always better to have, better to ask somebody who's experienced with methadone usage. So when we started patient on methadone, actually we got methadone in 2018. And I think we started methadone only in 7 patients in 2018. But in 2019, I think it went on to 25 patients. And in 2020, I think we had more than 7,500 patients. So when you are experienced, you will try to use methadone more. And that will give good results also. So if you have any doubts,
sir, one or two specific doubts, sir. But the thing is,
yes.
what is the ease of availability for methadone in India at to date?
Okay. So methadone is produced by only one pharmaceutical, that is Busan Pharma, and it is available in India. And if you have a RMI license, that is recognized medical institution status, with that you can purchase methadone. So
okay, got point. In the second case scenario, which we had discussed about the CA pancreas, the patient was basically having morphine, tramadol, paracetamol, amitriptyline, gabapentin. All these medications were on. So basically, is it not good? Then in that case, the patient, we should go for an intervention like celiac plexus block, or maybe put alcohol over there and ablate the celiac plexus, or maybe do a RF ablation, rather than basically giving all these so many medications to the patient. Because in my personal experience, I have done a few cases of celiac plexus block, alcohol ablation I have done, and the patient had phenomenal results. Your view?
Yeah.
Hello.
Sunil sir? I think
He has lost the net.
Yeah, I think Sunil sir has lost net.
Ma'am, please, can you comment, ma'am?
Can you
Thank
please
you
repeat?
for asking that question, Dr. Dipesh. Pancreas is additional. Sorry, my I was out of the session. So if we are doing a celiac plexus block, it should be done early in the course of illness, because otherwise the celiac plexus anatomy will be changed and may not give that much good results. And this patient actually was unable to move from the home. So they were finding it very difficult to bring the patient to any place. And we thought maybe methadone would give good results also. So that's why we started there on methadone. So as you told, there is a role for the celiac plexus block in the management of pain with the carcinoma of the pancreas, and should be done early enough so that the anatomy of celiac plexus will not be changed.
Okay, thank you.
Yes, sir. I have a couple of doubts.
Yeah.
One thing, what you talked about the tolerance of morphine. Regarding that, just wanted to know whether that tolerance go away once we stop and give a breakage for few duration of the time. Whether we stop for a month or two, replaced by methadone, and again we start morphine, the tolerance same remains or it is gone? It's a permanent tolerance or a temporary?
Okay. So tolerance with opioid is not very common. It's very rare. That's what literature says. But once you break the tolerance with methadone, then maybe for I don't know actually the answer, but I believe that maybe if you again start the patient on morphine, if you want to, then maybe after some time, I don't know how long after that the tolerance will occur. I'm not sure about that.
Okay, thank you. Second, sir, it may look funny, but there was some question in the mind.
Yeah.
Seeing to the methadone's duration of action, I think in the initial palliative management to start with, because it has a 12-hour duration of action, and patient is competent enough and physically fit, so maybe having a less side effects, less comorbidity. So initially, rather than giving a starting to a morphine in an initial phase of palliation, we can start with methadone and then switch over to morphine, rather, because morphine has a 4-hourly action, so it is difficult to give every 4 hours. So I think that it can be used at that place also, as well as in the terminal end of life care patient, we can switch over from morphine to methadone, because there is a longer duration of action with a renal safe. So, and we are not worried about the torsity effect also. So in a later stage of end of life care, I think methadone could be a wonder drug. What is your opinion on that? Both the points.
Okay, thank you, sir, for that question. First of all, regarding a terminal patient, then the most important thing which we need to understand is methadone will take about 5 to 7 days to get the blood level stabilized. That means it will take 5 to 7 days to get the proper pain relief. So if we start patient on methadone in the terminal state, then actually the patient will not have pain because it will take 5 to 7 days. So it is not wise to start the patient on methadone if the patient is terminal. You can say,
sir, over and above the existing drug, morphine he is taking, we can initiate the methadone in the later side of the, when you see that next now the more than a week is not remaining, more than 1 week, 1 or 2 week is there, according to the end of life, what you are predicting. So you can start methadone so that at the end of the week, it will be a less troublesome for the patient to tolerate the pain and everything.
Yeah, if the patient has 1 or 2 weeks to live, then maybe, as you told, in addition to morphine, methadone can be given as an adjunct or in a small dose. That can be done. And the first question was, can we start methadone in patients with severe pain rather than starting on morphine? So there are various opinion on this. And one thing which we need to understand is the methadone's half-life and the time to give the sustained pain relief is 5 to 7 days. If the patient has acute pain, it would be better to control the pain with a short-acting pain medication. Then only we can find out the dose required for this patient. So that's why we always start the patient on a short-acting pain medication. But there are some people or some doctors who start the patient on methadone also. There are various regimes. So that has also been advised. But I think for us, it would be better to start the patient on short-acting pain medication and then only switch over to methadone. Because the patient may tell you, sorry, I will not be able to take this every 4 hours. There are a lot of medications. Can you reduce the number of medications? So in such situation, maybe after you find out the stable dose of morphine, then switch over to methadone so that you can give it on the BD.
So, sir, what you said, I could not get it. The army license is required for methadone to get it?
Yes, RMI status.
Army status, but as a doctor, how can we get an army status?
It is recognized medical institution status. So if you are working
RMI,
in a hospital,
RMI,
yeah.
RMP will not get it.
No, it's RMI.
RMP will not work.
RMP can also work, but the way to get opioids by registered medical practitioner for his private use is a little bit complicated.
Okay.
You will get it for an RMP status. You might get it, but you'll get in a very, very smaller dose.
True.
Extremely small dose, which is not going to work for your patients.
May not be a 1 strip or 2 strip also.
No.
And they are actually specifying the dose which you can keep with you. I think it is 20 tablets, 10 milligram morphine, something like that. I'm not very sure, but it is very small dose.
So still the law is not pro-palliative.
So you need to have an institution that the RMI status have to be there for your setup, and then only you can actually get the adequate amount.
So RMI is more reliable than RMP.
I think so.
Madam, we had a discussion about the last session with the regional coordinators also, and we came to know and concluded that it has been come under the drug controller, but still it is not completely taken over by the drug controller in Gujarat. But what they were saying, that now onwards the license for narcotic drugs will only be given those who are trained in palliative, and only the anesthetist degree will not be allowed. So is it going to be like that? So it will be a trouble for most of the anesthetists who are not trained into palliative to get the narcotic medications, because they are the main user as on today. In any of the institute or hospital, if you see, it is on the name of a anesthetist or someone. So kindly elaborate on that, whether they all also will have to go under the palliative session, And another thing is whether this palliative course will be sufficient enough to enroll us as a RMG for the narcotic drugs, or additionally something is to be done.
You are absolutely right. Whether it is an anesthetist or an oncologist, he or she must have a proper hands-on training. It's been recommended that it should be 15 days of training, minimum 15 days of training in pain and palliative care, so that you are able to, then only you are authorized to use ENDs as such. So that is an important criteria. So for an anesthetist, no doubt he's an MD, but he must have at least minimum 15 days of training in pain and palliative care. And I think, for this particular fellowship course, I don't know, sir, Sunil sir might be able to tell you more about this. If it is,
Yeah. Sangmitra.
Yeah.
Our online courses has been approved by Drug Controller of Kerala as a qualification to apply for RMN status. Actually, our drug controller, Kerala drug controller, has approved. But in your state, you have to see. But we think that this will be enough. And if you want, we can help you with this, because we can send you the order from our drug controller and can get you connected with our state facilitation team, so that they will help you to procure the RMN status.
So kindly send a letter when you give a fellowship letter. At that time, send this letter copy also to everyone of us, so that it can be helpful to us in future.
Okay.
Right?
Okay. Yeah.
Yeah. Thank you. So I think today we are concluding this fellowship, and I am very grateful to TIPS India and all this TIPS Eco program conductor, and especially Sangmitra and Sri Priya, who are constantly available to guide in any topic with all the faculties. So it was a nice journey to be on a educational way. As such, we will have to keep all these lectures with us, because now at this age, it is difficult to remember everything. So we'll have a ready reckoner. We'll make a ready reckoner, because after certain age, certain thing doesn't go inside the brain, but we have to have a reckoner. So we will keep the ready reckoner with all the PPTs, printout and all those things. But we really thank you everyone who are creating this nice program online with a timely startup and timely finishing also. So it will be a very nice journey throughout the day. And we are very much privileged to be in this batch. And probably if there is a few programs like that in future, be in touch with us, so that in your information list, keep all these email IDs, so that any circular which goes out, which can be received by us. So I think it was a nice journey. Only thing is, just for a correction, I just wanted to let you know one thing. Okay, you have to have a customized feedback, because in all feedback, even though case was not presented, do you like the case presentation? Has it changed the management? All those things, how can we write yes or no if the case is not there, right? And every question may not have been answered, because it is not according to the session. So rather than keeping a similar feedback, either you can have certain, may not be a daily basis, every session may have a 4 or 5 feedback, which may be sensible to that particular session, or like an assignment. What you club the 2-3 assignments together, at that time you can put the feedback also with the assignment. So it will be more justifiable, right? Because similar answers will come otherwise in a feedback. So better feedback we can prepare. It will be better for future team. So I am very much thankful, and again, heads to you for conducting a course in a difficult scenario also, and finish the thing, right? And we will be in touch with the regional team as and when required, right? Okay.
Can I request everyone to, open their videos? This is the last day.
Sir,
So
Samitra, I would like to thank sir because senior colleagues like him make us encourage and to go forward. And thank you for the feedback which you have mentioned about each session feedbacks. So, Supriya, I think we need to do something about that.
Yes, sir. It has been noted down. Definitely, we will work on that.
And sir, it was definitely a very interactive session, sir. So first thing is whatever the queries were there, they were basically addressed to in a very rightly manner. And and it's a real eye opener for us, because the thing is, it's a entirely a different stream for each of us. Maybe I'm practicing anesthetist as well as pain. I have done my fellowship in pain management also, but palliative care was entirely a different ballgame. The thing and the kind of the basically the sessions which we should have with the patients, and the approach towards the patient, their relatives, and to pain management per se, and the management of these palliative patients is entirely different. And we are really thankful for a real good sessions over here at this platform. Thank you.
Thank you, Dr. Nitesh.
Dr. Mittal, you are muted, sir.
Yeah, good evening, everyone. It was a really excellent course for me, although I was not sure how I will utilize this knowledge, because I'm not actively practicing these days. I am kind of a retired oncologist now, but definitely any knowledge is useful and it can be used at any level, any time. So it was a very eye-opener course for me. Although I had practiced oncology for many years and had prescribed medications for pain medication, but now I know how the palliative care, how important is the palliative care. I would recommend that every cancer hospital should have a full team of palliative care doctors who can really help these cancer patients. Thank you very much.
Thank you, sir, for those comments. I think you will be able to guide your juniors to go through this course, or your experience will guide them to serve the patients better.
There is no retirement for knowledge. Better, sir, if I could say so. Because even if you are not practicing, of course, your years of experience will definitely help others to bring light to persons.
See, actually, the palliation is required in most of the specialty, and it is more observed into oncology because it has a long pathway. But as described in the end of life care, every specialty will have at least a palliative management, maybe from 15 days onwards to maybe 2-3 years. So I think all the specialty should have that knowledge. Actually, the knowledge of palliative medicine is very limited, and doctors are mostly interested in curing the patient, treating the patient, and not giving a palliation. So I think the awareness should increase. And I hope that in Gujarat, there are a lot of scopes for palliative. Can a TIPS have a branch over here in Gujarat, so that we can increase the palliation management in Gujarat also? There are very limited institutes in Gujarat for palliative management.
Sir, where are you working?
Pardon?
Where are you working, sir? Which hospital?
I am just working with HCG group of hospital in Bhavnagar.
Okay. Okay.
But in Gujarat also, not a single hospital which is a dedicatedly palliative care center in Gujarat.